Krista Capehart, and I am a pharmacist, and I am a clinical professor at WVU at the School of Pharmacy, and also the Director of Professional and Regulatory Affairs at the Board of Pharmacy, and I've been the pharmacy lead for all things COVID for kind of what feels like eternity. Feels like Groundhog Day.
And I'm Dr. Lisa Costello. I'm a pediatric hospitalist in the Department of Pediatrics at WVU, and I've served as the medical lead for the Joint Information Center within the state's Joint Interagency Task Force for COVID-19. So I've had the honor to get to work with Dr. Capehart very closely, as well as Mitra and Elizabeth and Jay, as we started these Project Echo COVIDs all the way back in 2020, and now kind of just have them as pop-ups. There were considerable changes to the COVID-19 vaccine recommendations that happened at the end of April and the beginning of May. I know Dr. Capehart gets a lot of questions about them, as do I, and so we thought it would be good to bring those updates to you, and we hope that we could answer any questions that you may have. So are you able to see the slides?
Yep.
Yeah, just make them bigger in the presentation. That's perfect.
All right. So Dr. Capehart will kick us off, and please chime in with any questions. We do want to thank our colleague, Dr. Julia Frostino, who works on our team. She always makes our slides pretty. And so we just wanted to say thank you to her. And I will turn it over to my esteemed colleague, Dr. Capehart, to take us through these updates that we all are now seeing when it comes to COVID-19 vaccination.
Yeah, it makes it really nice to have Julia Frostino, Dr. Frostino, working with us, because I no longer have to worry. I can just get the information out there, and then she takes it all and makes it look really nice, and she's just fabulous to have around. All right, so let's get started with the updates and the clinical considerations. So we had originally had the monovalent messenger RNA COVID-19 vaccines that came out in December of 2019. And if you'll remember back, we were using those for a primary series, and then we had a bivalent that came out end of August, 1st of September. We are no longer utilizing the monovalent for any doses any longer. So they're no longer authorized as either boosters or primary series. And so any monovalent doses that you do have should be documented as waste and eliminated from your inventory, because we're not using monovalent any longer. The Omicron bivalent vaccines are now used for all COVID-19 messenger RNA doses administered. I'll talk a little bit about one product that is still being used that's monovalent, just to make sure everybody is aware, but all of the messenger RNA COVID-19 vaccines that we're using are only bivalent now at this time. And then the recommendations that we're going to show you what is now recommended. While everyone is calling this the simpler schedule and the simpler recommendations, it is, but it does get simpler the older the patient is. So it really comes back to the individual's age, vaccination history, and whether the patient is immunocompromised or not. So we'll get started. So we have the bivalent vaccines, just to review. We had original vaccine guidelines that came out in August of 2022 with that product. I think it rolled out September 1st. And then we have these new updated guidelines that rolled out April 18th with some additional updates on May 1st. So this new product, or the product that came out, It's bivalent. It has the original strain and then the Omicron BA.4, BA.5. Now, it's important to realize there are still just two strains. The BA.4, BA.5 is the same genetic information. So that's why it's just a bivalent. And so this helps us to target the those current circulating strains. And even though we are seeing different strains starting to circulate as we head towards summer, that genetic material is still present on the circulating strains. So we are still seeing efficacy with this bivalent product. All right. So I know the last time we were here, we had talked about we were expecting that there would be meetings of VRBAC, which is the advisory committee for the CDC, excuse me, for the FDA, and then ACIP, or Advisory Committee on Immunization Practices, the CDC's advisory committee, that we anticipated they would be meeting in the spring. And we thought we would be moving from monovalent to everybody utilizing bivalent and see some changes. And really that's what we saw in April. And based off of the studies that we have, we now know that this bivalent product can induce immunogenicity, either given as a primary series or as a booster or as an additional dose. And that actually with that bivalent product, the antibody titers were about 25 times higher than just the original monovalent strain. So that's really why we saw that switch over to just using the bivalent strain. And then in May, we saw additional guidance for the 6-month and up immunocompromised. And we will find out more information come June about what additional products we should anticipate for this fall. So an overview of our new recommendations. We're specifically talking about in these recommendations, those who are not moderate or severely immunocompromised. And then Dr. Costello will talk about the recommendations for those who are immunocompromised. So at initial vaccination, depending on the product, children 6 months through 4 years. So think of these kind of like what we do with flu. If the child has never been vaccinated for flu, they have to get 2 doses to kind of prime and get that immune system working. Very similar here with COVID. So at initial vaccination, children 6 months through 4 years, they're going to get either 2 or 3 bivalent, depending on which product you receive. And children 5 years of age and up are recommended to get either 1 or 2 bivalent. And we'll look at those specifics here in a second. If the child is 6 years or older, who is unvaccinated or only got 1 monovalent dose, they are only recommended to receive 1 bivalent messenger RNA dose. Those 65 and older may receive 1 additional bivalent dose. Remember, they were able to get a bivalent dose in the fall, so now they're eligible to receive an additional bivalent dose. Keeping in mind that we'll talk a little bit about staying up to date. Notice this is a May recommendation, so they do not have to get that additional dose in order to stay up to date. And then that final bullet point talks about Novavax, recognizing that Novavax is a different mechanism. It's an adjuvanted vaccine, is not a messenger RNA vaccine. And with the Novavax, it is still a monovalent vaccine. It's the only COVID-19 monovalent vaccine still available in the United States. It is authorized for those 12 and older who previously received 1 or 2 monovalent doses as a primary series. And then they are actually recommended to get 1 additional bivalent messenger RNA dose. So they completed their primary series with Novavax. It's recommended that they get boosted or get 1 bivalent messenger RNA dose. There are, however, some limited circumstances where it is permissible to use the Novavax as a booster, but it's very limited circumstances, and I'll go over those with you in a minute. So essential summary, you're 6 years and older who are not moderate to severe immunocompromised. If they got their 1 dose of bivalent and messenger RNA, then they don't need any additional doses right now. And we're going to talk about some specific situations for those ages who are not immunocompromised. And then in those who are, we'll look at additional doses. So what they will need here. So now we're going to look at those messenger RNA doses. Now, this is really big because one of the big issues that we've had has been, it's been so easy to mix these products up, especially with Pfizer, because your Moderna and your bivalent for each of the age groups looked exactly alike, except on the label it would say bivalent. So of course that was a problem. And so by getting rid of the monovalent, the use of the monovalent products, we went from 11 messenger RNA products down to only 5, making it much simpler to maintain your inventory and hopefully to select the best product. I will tell you that all Janssen is no longer available for use. So the J&J product, it has now all expired. So there's no more Janssen available in the United States. So we simply have the 2 messenger RNA bivalent products and the 1 Novavax monovalent. I do want to draw your attention, however, these are actually left to right, with age group being your pink, being they're labeled for your youngest age group, and then your blue cap is labeled as being the older age group with Moderna. We're going to look at the recommendations here in a second, and I want you to pay close attention because with these new guidelines with Moderna, you're not following that label. You're using from different vials depending on which dose it is and how old the child is. So I just wanted to point out the colors of those caps. All right, so when we go from little ones to the adult ones, you'll see this gets much, much simpler. These charts and tables are available on the CDC's website for the interim COVID-19 vaccine clinical considerations. They are actually also in the EUA fact sheets for the individual products. So if you look at an unvaccinated child age 6 months to 4 years, again, we're talking about one that does not have immunocompromise. If you're going with Moderna, they're going to get 2 doses, and it is a 0.25 ml dose, and we're using the dark blue cap with the gray border. That's the higher age group. It's not the typical product that we would usually choose for this age category. So make sure you're looking at which vial you're choosing from. And again, the doses, it's dose 1 and then dose 2 is 4 to 8 weeks after. Unvaccinated Pfizer individual, they're going to get 3 doses of 0.2, and maroon cap, which is the product we've been using. Dose 1, dose 2 separated by 3 to 8 weeks, and dose 2 and dose 3 separated by 8. Now, if the individual has had 1 dose or 2 doses of monovalent Moderna, you're going to stick with that Moderna, and they're going to get 1 dose of bivalent. But take a look at this. So if they've had 1 dose of monovalent Moderna, you're going to give them 1 dose of 0.25 dark blue cap, 4 to 8 weeks after their monovalent dose. If they've had 2 doses of monovalent, you're going to give them a bivalent Moderna, but it's 0.2 and it's out of the dark pink cap with a yellow border, and it's 8 weeks after. So you have to be very careful to pay attention to their vaccine history then determining which product, because that's going to change your concentration, to see which what the dose is and what the duration is. So in this age group, it can be very tricky. So making sure you're looking at this chart for every single patient. If they have had 2 doses of monovalent and 1 dose of bivalent Moderna, then they're done. With the Pfizer, it's much simpler. They're going if they've had 1 dose of monovalent, they'll need 2 doses of bivalent. If they've had 2 doses of monovalent or 3 doses, they will simply need the 1 dose of bivalent. So moving on to the 5-year-olds. This is kind of that transition age for everybody. So particularly, again, going back to the Moderna, if they're unvaccinated, they get 2 doses out of that dark blue cap with the gray border, 0.25 mLs, separating your dose 1 and dose 2 by 4 to 8 weeks. If they've had 1 monovalent dose, they're going to get Moderna 1 bivalent dose of 0.25, again out of that dark blue cap. And if they've had 2 monovalents, they would need 1 dose, 0.2 mLs, and it's out of the dark pink cap with a yellow border. Your Pfizer, however, you are using the product that goes with the labeled age. We're using the orange cap, and whether they're unvaccinated or 1 dose of monovalent or 2 doses of monovalent, they would only get 1 dose of Pfizer out of the orange cap. And you can see the dose, the ages there. So, and at the bottom half of that chart, if they've had a dose of bivalent, then they are done in the age 5 category. All right, you're 6 to 11. I told you the ages, as they get older, the chart gets much simpler. 6 to 11 years old. Now with Moderna, we are only using that dark blue cap with a gray border product, which is the product we would anticipate using in this age group. So unvaccinated, notice nobody in this age group is getting more than 1 dose, because at this age group, we're making the assumption based off of the data that was collected that everyone fits into one of two categories. They've either had COVID or they were vaccinated in this population. So we have enough people exposed that this is what they would need. So unvaccinated, they're only going to get 1 dose, whether it's Pfizer or Moderna. If they've had only only 1 dose of monovalent of either Pfizer or Moderna, they're only going to get 1 additional dose. And at the bottom half, you can see if they've received a bivalent at all, they're done at this point. 12-year-old and up, same thing. If they're unvaccinated or just got monovalent products, they're going to get 1 bivalent dose. Very simple, at least 8 weeks after their last monovalent dose. If they've received a bivalent dose, then they're done. The exception to this is, and Lisa will go over it more, is the 65 and older population, because they do have the option. Notice I keep saying option. They're considered up to date as long as they get 1 bivalent dose. But they do have the option of getting an additional bivalent messenger RNA dose 4 months after their first dose of a bivalent messenger RNA. And you'll see if it was Moderna, they're going to give a 0.5 ml dark blue cap. If it's Pfizer, it's a 0.3 ml, the gray cap with the gray border. So, it definitely gets much simpler, but for your baby ages, I would most definitely keep the chart and so you know which product to use. So now I want to focus a little bit on Novavax, because it is our 1 monovalent product still out there. It's only authorized for use at all in ages 12 and up. So if they've had 1 or more dose of Novavax, they really should be getting a bivalent vaccine. either Moderna or Pfizer. And they should be getting that dose 8 weeks after their last monovalent dose, which would have been after their dose of Novavax. So again, you're 65 and older, they can get that additional dose of bivalent 4 months after their last one. So Novavax remains a 2-dose primary series for 12 and up, but it's only authorized as a booster in people 18 and older. So they have to have previously completed a vaccination using any FDA approved or authorized COVID-19 vaccine. They cannot have had any other previous booster, and they're unable to have like a messenger RNA, so it's contraindicated, or some other, or they're unwilling to get a messenger RNA, or they decide they would just rather not get a booster. So if any of those pieces exist, then they are eligible for a Novavax booster, but they have to wait 6 weeks after completion of their primary series. So that's where a Novavax booster comes into play. So now I'm going to turn it over to Dr. Costello, and she's going to tell you about these additional doses in our 65 and older and our immunocompromised.
Well, thank you so much, Dr. Capehart. Each time I get to present with you, you make this very complicated, simplified schedule more understandable. So thank you for all of your work. So as Dr. Capehart said, there are some additional considerations for the older population. We know that this group continues to be the group at highest risk for severe disease, hospitalization, or death. And I think it's important that we all be reminded that that's what these vaccines were studied for, to prevent people from getting really sick, needing to stay in the hospital, or dying. I think that we've continued, as we talk at the end a little bit about communication, it's really important that we continue to emphasize that. So as Dr. Capehart said, people who are 65 and older, they may receive an additional 1 Omicron bivalent COVID-19 mRNA dose as long as it's been 4 months after their first bivalent. So what should that be based upon? The clinical judgment of a healthcare provider, again, that person's risk of severe COVID-19, and a person's personal preference and circumstance of who they may be around, or they want that updated protection. So what about the immunocompromised? As Dr. Capehart said, this was a change that just happened on May 1st. So prior to May 1st, the youngest among us that are considered moderately to severely immunocompromised hadn't really been recommended to have those additional doses, but that changed this month. So people who are 6 months through 4 years of age, considered to be moderately to severely immunocompromised, and they have received 1 dose of a bivalent mRNA vaccine, they should get that 2 months following their last recommended bivalent mRNA COVID vaccine dose. So as you can see with everybody else who would be considered to have a competent immune system or not immunocompromised, that's a 4-month interval, whereas those individuals who are moderately to severely immunocompromised are 2 months between doses. So people ages 5 years and older, again, moderately to severely immunocompromised, previously received an Omicron bivalent, they may receive an additional dose at least 2 months after the last bivalent dose. I want to point out, in those young ages, they want you to receive the same type. And so from, as Dr. Capehart said at the onset, that's where an individual's vaccination history comes into play, because you want to make sure for certain ages, it's recommended that they get the same product. Whereas when you get a little bit older, there's more capability to choose either product. So for everyone that are 6 months and older considered to be moderately to severely immunocompromised, they can get an additional bivalent mRNA doses as deemed fit by the healthcare provider at least 2 months apart based upon that level of immunocompromise. This is a new change. So the updated EUAs basically provided more flexibility for a healthcare provider to determine that an individual may need multiple doses to maintain updated protection. We, or at least in the meetings of the Advisory Committee on Immunization Practices, they really honed in on those people who have really compromised immune systems. So stem cell transplant, CAR T therapy, B cell depletion, and there are others. And this basically now allows the healthcare provider to make that determination of if a person really should be getting multiple doses of an mRNA vaccine 2 months apart. And as Dr. Capehart said, we'll find out more next month as to what the fall will look like. But I think it's important, particularly when we get into the fall, knowing what is going to be recommended. For right now, these are the recommendations based upon this Omicron bivalent mRNA product. And so one of the questions we frequently have received throughout the vaccine rollout is, well, who determines an immunocompromised state? It's still self-attestation. So an individual who considers themselves moderately to severely immunocompromised, they self-attest to that. It doesn't require additional documentation. The EUA basically allows for providers, if you have a patient who is very moderately to severely immunocompromised and you think they should be getting this updated protection, you can make that recommendation and encourage them to do so. So what are some additional clinical considerations? As Dr. Capehart went over the different products, we really have moved away from this primary booster, fully vaccinated kind of discussion. I think the analogy to flu when we're younger, like my daughter who's 15 months, when she got a flu shot for the first time, she had to get 2 doses. Now in subsequent years, she'll get the yearly flu vaccine. And so that what she would be considered to be up to date. And so that's really what we're talking about with COVID-19 is how do we encourage people to stay up to date? And really for 6 months and older, we really encourage people to get the recommended number of COVID-19 vaccines. We know that vaccination continues to be the best protection we have for those really severe outcomes. Even if you test positive for COVID, having been vaccinated, you have better outcomes. And I think that's important that we continue to message that. There's been a lot of discussion about the public health emergency ending on May 11th. Just because the public health emergency ended doesn't mean that COVID is gone. It is still in our community. There are still 1,000 people a week across the country dying secondary to COVID. And if we don't maintain our protection through having people be vaccinated and people who then get the disease, we potentially could see surges again, and none of us want to see that. So here's basically the simplified, quote unquote, guidance that the CDC has come out with for what's considered up to date. Everyone 6 years and older, you're up to date if you've received one updated Pfizer or Moderna COVID-19 Omicron vaccine. It's more complicated, as Dr. Capehart went over, for those younger populations. So 6 months through 5 years, if you got a Pfizer COVID vaccine, you're up to date. If you're 6 months through 4 years, you got 3 doses of COVID, and at least one of those were that bivalent. For that 5-year-old, you want to make sure that you got at least one updated bivalent COVID dose. For children ages 6 months to 5 years who got the Moderna COVID vaccine, you're up to date when you get 2 Moderna COVID doses, and at least one of them being that updated COVID-19 Omicron bivalent dose. And then people who are unable or choose not to get an mRNA vaccine, you're considered up to date if you get the Novavax COVID-19 vaccine approved for that age group that Dr. Capehart went over. So the side effects have really remained consistent throughout the rollout, including with the Omicron bivalent formulation, which is now the only authorized mRNA product that we have. So pain, swelling, redness at the injection site. We can see fever, tiredness, headache, chills, muscle aches. And then the lymphadenopathy is a question that I know Dr. Capehart and I frequently get. You can see swollen lymph nodes with the disease of COVID or with vaccination. What we tend to hear in people who've received vaccine, particularly the lymph nodes closest to where the injection was, you might have some swollen lymph nodes there. For our younger children, again, pain and tenderness at the injection site. You could see irritability, crying, drowsiness, sleepiness, which are pretty common with all vaccines that we would see as a expected side effect. What about co-administration? I think this is really important. We have frequently gotten questions about this. It is now considered to be best practice to give the recommended shots that a person is due for at that time, including COVID-19 vaccines. And so if you're giving multiple vaccines at a single visit, you want to administer each injection at a different site, particularly different extremities. If you're, say, giving 2 vaccines, we commonly see co-administration of vaccines occur. And so we want to continue that standard practice, and COVID-19 should be given with those other recommended vaccine. The one kind of situation to be mindful of, and I've started to see more communication about this, is for the Mpox vaccine. We recommend that you kind of follow the clinical consideration for individuals who might be high risk for Mpox. There are special considerations of whether you should wait between COVID dose and Mpox dose or give them at the same time. And so if you're faced with that situation, definitely look it up and then consider it based upon that individual patient's risk factors and needs. Another area that frequently gets brought up is, what about somebody who's had COVID? So the recommendation has been pretty consistent throughout that if you are actively infected with COVID, you want to wait until your isolation period has ended. That is more so to protect the person giving the shot. We know that there have been people who get a vaccine when they have COVID and they do fine. It's solely an effort to try to protect the person giving the shot and then the other person that they would be around, because most of the time this would be in public. The one thing to consider is people who've recently had a SARS-CoV-2 infection. They may consider delaying the vaccine by 3 months from symptom onset or a positive test. And that's, again, a may. It's important to make these individual determinations. If you're at higher risk, you may want to go ahead and get that shot. If you're traveling to an area that is seeing increased COVID activity, you may want to make sure that you have that updated protection. As Dr. Capehart went over, there's been many changes to the product and the labeling of such. As we've seen throughout the pandemic and the vaccine rollout, there can be errors that occur. So if an error doesn't occur, it needs reported to VAERS, the Vaccine Adverse Event Reporting System. In the state of West Virginia, we encourage you to reach out to Dr. Elizabeth Sharman, who works on the team. She is a pharmacist and she can help further guide as well as monitor different errors that might be happening in West Virginia so that we can provide some additional guidance. There are these magnets available that I'm going to talk about next, of some resources that we have available for individuals if they would want. The state continues to work on this, as Dr. Capehart and myself are part of that team. So here are just some communication resources. We over a year ago, in March of 2022, launched a COVID-19 vaccination due date calculator, knowing that it was very complicated to know what would be considered up to date. And so this due date calculator has been updated to reflect the newest guidelines that came out that we discussed here today. And so this is a resource that you can use for yourself, for your patients, for a family member, a friend. It's available at vaccinate.wv.gov. if you are part of a community health center or a hospital or your own private practice or your own pharmacy, you can actually embed the calculator on your own website. It'll be updated based upon new recommendations. They're all updated at the same time. So if you want people to be able to maintain or stay on your website, you can embed this, and you can reach out to myself, Dr. Capehart, and we can get you connected with the people who can help make that happen if you would so desire. But basically, it will give you when your recommended due date is. It also allows you to schedule the vaccine, and it also has a medical info page that, based on some of the information that Dr. Capehart and myself went over, it is available there as kind of a one-stop shop, if you will. So that is just at the end of the page where the medical info button, it will provide you a summary of the entries, and it has some links to some common resources like clinical considerations, those charts. I want to emphasize again what Dr. Capehart said. Please keep those chart handy on the calculator. If someone puts in an age of under 5, it directly recommends that they go to a healthcare provider, and it provides a link to the recommendations. It's really too complicated for us to be able to kind of provide that calculation, because for those young individuals, it still is really based upon how many doses you've received in the past. We also have our ongoing vaccine messaging kit. This has been available since the fall of, well, I guess the winter of 2020, when the vaccines were rolled out. These are updated to reflect the newest guidance. You can download the image, copy the text, post straight to your account to continue to spread information. There's also posters available and other resources, the magnets I mentioned, buttons, lanyards. You can go to covidvaxwv.org/order, and these will be shipped to your center. And then we also put together early this year kind of just a front and back page document of all the different resources that are available. You can access this at that messaging kit, and this just provides different resources that are still out there for you to promote COVID-19 vaccination, and all of these materials get updated based upon new guidance. So thank you all for joining in, and thank you to our friends at Project Echo. With the public health emergency ending, I think that perhaps these echoes might get sunset, but I think it was important to bring to the community these updated guidance, because we have gotten a lot of questions throughout the month as these guidelines went live. And I just want to say thank you again to Dr. Capehart. She's done so much throughout this pandemic, behind the scenes, and always providing sources of information. So I'll stop my share, and we will answer any questions that anyone may have.
Yes, thank you guys so much. That was wonderful. You have great resources, and the work you do, really appreciate it and appreciate your time today. Does anybody have any questions? We did have a chat saying these have been great sessions with lots of useful information, and thank you. I completely agree. We'll keep them as pop up. I'm hoping, I think we're all hoping things don't get worse, but the updates, maybe we could have those every once in a while, because things do change, and that does really help educate. I think a chat came in.
This is a good question, Dr. France, and Dr. Capehart. So basically, from our communication resources, have found people don't know what bivalent means. And so we in West Virginia have tried to refer to them as Omicron or updated. I think a lot of the national materials that you see now refer to them as updated. As Dr. Capehart said, next month we'll find out if there's going to be a change, to the formulation for the fall. And so the Omicron bivalent mRNA vaccine is the same as the bivalent mRNA vaccines. When we talk about homologous bivalent mRNA vaccines, that's basically meaning you're receiving the same product. So for that younger population, if you started with Moderna, you have to get Moderna. If you started with Pfizer, you have to get Pfizer. Whereas when you get older, you can mix those, which we see with, other vaccine products. So as you get older, say you got the other shots you've got have been Pfizer. If you wanted to get a Moderna, that's okay, as long as you're a certain age. Did I touch on that, Dr. Capehart, right?
You got it exactly right,
I think the
as
one
always.
the one messaging consideration is what we found is people don't really know what bivalent, and one of the things what we've tried to do with the calculator is like people don't know what they got. So, people are like, oh, I'm up to date. And you ask, well, when was your last shot? And they say, well, it was March of 2022. The bivalent Omicron shot wasn't even authorized until it went live, like Dr. Capehart said, on September 1st, 2022. So really, for most of these people, if you've not had a COVID-19 shot since September 2022, you're likely due for an updated protection. And what we're finding is people are like, oh, I'm up to date. Well, you may have got that former formulation, that monovalent product. So I'm glad you brought that up, that question, Dr. France, because I think it's important that we remember, and Dr. Capehart, when this bivalent product became available, which was last September. And so people who haven't had a shot since then, they're likely due for an updated protection.
Thank you so much. And thank you for the question. Any other comments or questions?
I'll just drop into the chat some of the websites if you want to then share that with the email that you send out usually afterwards. That might help as well. Our team continues to work even though the public health emergency has ended. There's still, Dr. Capehart and I spend many hours working on this with a great team. And so we just want to make sure that people still have the resources available so that they can share that information to their networks.
And I love it when people are like, aren't you glad it's over? And I'm like, sure, yeah, because I am still distributing those vaccines and therapeutics every day.
Yeah, and I think that it is important. We're in, we didn't talk about this, but the public health emergency ended officially on May 11th. There still is federal product available when it comes to COVID-19 vaccines and therapeutics. It's basically until that supply runs out, then, we'll have to go to the more traditional means of acquiring that. And so Dr. Capehart, myself, the team, we're working on, trying to get an assessment of that. We've had very limited quantities of some of the vaccines, particularly like Moderna for younger. Our state only gets a very, what I would consider small allocation. And so, Dr. Capehart works really hard to try to get it distributed across the state. But as we talked about in that young population, if you started with, and you've gotten, the one type of product, you need that to further complete. And so we only still have a limited supply of some of the products. But, so it might be a little bit harder, particularly with Moderna. The Pfizer, I think we have a little bit of a more robust supply.
Well, and they've made some of the changes. So, and that's why I wanted to point out like which product you use. Moderna has helped us out with the 6 month through 4 years because they reduced their order quantity to 20. So even though I have a small amount, I can send it a lot of places. Pfizer, however, we get the same amount, which is very small, and the smallest order is 100 doses. And so basically you send it to one place and then you have to send 4 people to go pick up doses from that one place, which makes it much more difficult.
So stay tuned, there will be changes down in the future in regards to how, these vaccines are acquired. They are going to be part of the VFC program. So there will be ongoing changes as we continue to move forward, dealing with COVID-19. But there is, for now, even though the public health emergency has ended, there still is federal supply available for the vaccines and some of the therapeutics. So if you ever have any questions, please reach out to Dr. Capehart or myself, and we'll help connect you or help answer as best that we can. But thank you to the Project Echo team. And I don't know if anybody else has any other questions. Otherwise, I'll turn it over to you, Elizabeth.
No worries. I think I didn't see anything else in chat, so I think we're good. But please do, if you have questions, pass them along, or if you need another pop-up, Dr. Costello or anyone involved in this, please reach out and we can set that up for a future date. So other than that, we look forward to seeing you in the future, and take care and stay safe.
Thanks,
Thank you all
everybody.
so much. Bye.